Hi, CASW members. Sorry about that. My screen froze briefly, but hello and welcome. Thank you for joining us for another 90-minute session. I am so happy to already see your virtual names populating my chat function. If you haven't found that chat function already, please pop it open. Let us know where in the country you're tuning in from, your name, any other details you want to share with us. We also have a poll function up on that slide screen. So feel free to pop in there. Let us know where in the country you are tuning in from. My name is Alexandra Zanis, and I am the Social Policy and Communications Coordinator at the Canadian Association of Social Workers. You are joining us for a 90-minute long webinar. This is part 3 of a 3-part series on eating disorders and social work. If you want to pop open that abstract widget at the bottom of your screen, you can get a little bit more details about this presentation. The handout widget also has parts 1 and part 2 if you happen to miss those 2 incredible sessions. They are available on demand, so you can watch them anytime, as well as the session will be available on demand about an hour after the presentation concludes. You can see those blue and white icons at the bottom of the screen. They're widgets, icons. Those will be everything you need to access additional materials for the presentation, the Twitter function, the course completion tracker. That course completion tracker is where you will get your certificate of attendance if you are looking for one today. It will not generate until the platform has finished the session today. So please give it up to an hour. You can download it directly from the platform if you log back on an hour after the event, or watch your email. It should be emailed to you. If you haven't gotten it in your email, check your junk folder or log back onto the platform and download it directly here. We also have the slide function in the handout widget, part 1, part 2, as well as the CASW peer-to-peer support group. That place is your space to talk about the challenges of this new reality that we are dealing with. So please feel free to request to join that group if you are a registered CASW member, and utilize that space with questions, comments, anything additional that you want to say to fellow social workers across the country. I am going to pop open the speaker bio widget for everyone. You can feel free to exit that out, but we have some phenomenal presenters today. I am so happy to be joined by Ari, Aaron, and Caitlin, who are finishing up our, like I said, the 3rd part of our 3-part series today. Their organizations are also in their speaker bios, so please feel free to check out those organizations as well. They are doing some phenomenal work in this field, and as we know, social work is such a massive player in the field of eating disorder recovery. So with all that being said, I'm going to be on the back end. Feel free to use that chat and Q&A tabs. There's 2 tabs. If you have dedicated questions for the presenters for our little 10 to 15 minute Q&A period at the end, please use that Q&A tab. That way it doesn't get lost in the chat function. And feel free to type your questions throughout the presentation. We'll compile them. We might answer them during the presentation, towards the end in that Q&A. So feel free to use that box and ask any questions that you may have of myself at CSW or of our wonderful presenters. Also, if you are having tech issues, I do recommend using that Q&A tab just so that we can help you better in a bit more of a coordinated fashion than in the chat. I think with all that being said, I would love to pass it on. Let's see the results of this poll before I do. Okay, lots of you from the prairies. I feel well represented from being from Alberta, lots from Ontario and Atlantic Canada. Phenomenal. All right. Well, I'm going to pass it on. I believe we have Ari coming on, who's going to start us off. Ari, thank you so much for being here, and I so look forward to this presentation.
Thanks, Alexandra. Hi, everyone. We're really excited to get to talk to you today about creating connection in eating disorder recovery, strategies for ongoing support. My name is Ari Maharaj. I use he, him pronouns. I am the Outreach and Education Coordinator at the National Eating Disorder Information Center. I identify as someone with lived experience of mental health issues and have worked in community mental health for about 9 years now. I started in a post-secondary setting and then worked into community settings, and now I'm excited to get to do community education work at NEDIC while also having a reduced cost private practice for folks who experience financial barriers and ways to support them, while also getting to run groups through Sheena's Place that you're going to hear about later today. And I'm going to pass it over to Erin and Caitlin to give brief introductions too. So I'll start with Erin, if that's okay.
Yeah, of course. Hi, everyone. My name is Erin Houston. I am the Training and Education Coordinator with Body Brave, who we'll hear a bit about in a bit. I identify as someone with lived experience of an eating disorder. Throughout my late teens, early 20s, I was diagnosed with anorexia nervosa when I was 16, and have experience navigating kind of the pediatric eating disorder hospital system and community-based supports as well as a result of my eating disorder. So really excited to be with you today. During my time recovering from an eating disorder, I had a lot of interactions with different social workers, and so I have so much respect for the work that you all do, and hopefully some of these insights can be helpful to you as you navigate working with clients with eating disorders. And I'll pass it over to Caitlin.
Hi everyone, my name is Caitlin Axelrod. I use she, her pronouns, and I'm a social worker and the program and outreach coordinator at Sheena's Place in Toronto. I've been in my role at Sheena's Place for just over 3 years now, and I've been involved in research and volunteering within the eating disorders field for about 8 years as well. I became interested in eating disorders as a result of knowing many people with their own lived experience. And I am very passionate about providing low barrier mental health support, body inclusivity, and harm reduction, which we will hear a little bit more about today, both at Sheena's Place and in my work and life outside of Sheena's Place. So very excited to be here, and I will pass it back over to Ari.
Thanks, everyone. All of us are really committed to helping individuals who experience eating disorders and disordered eating, whatever that looks like for them, and regardless of whether or not they've received an eating disorder diagnosis. We all really believe that health is comprised of many factors. It's more than just our physical bodies and includes our mental, emotional, social, and spiritual and community well-being. We also understand that inequity and injustice can have really insurmountable impacts on an individual's health and health outcomes, and many of these barriers are far beyond any individual or community's control. But we believe that we can work together to help bridge those gaps. Unfortunately, experiences of racism, of intergenerational trauma, and of settler colonialism have had powerfully negative impacts on health. And that health in and of itself is an impermanent state of being. We do not believe that being healthy or pursuing health is an obligation an individual owes to society, nor is reflective of someone's value. We recognize the inherent worth of individuals regardless of their relationship with health. In the field of eating disorders, I think that relationship has been really complex. Both we and our clients often work with dietitians, with social workers, with therapists, and each of these professions have its own complex history with whiteness and colonization. In Canada, for example, dietitians participated in experiments on Indigenous children without their or their family's knowledge or consent in the Indian residential school system. Social workers have contributed to the removal of Indigenous children from their homes and sent them to residential schools or to foster care. Therapists, psychologists, psychiatrists have embedded whiteness into the Diagnostical and Statistical Manual of Mental Disorders, which continues to be the prevailing document utilized in the field. And these are just a few examples. Treatment and access to support are all still shaped by these things and the impacts of these traumas that sometimes folks with lived experience have had to encounter. As a non-Indigenous settler, we all see acknowledging these factors and actively working towards reconciliation is critical, especially in the context of learning about mental health, and learning about eating, and learning about bodies, and in learning about health, and the way in which these things interact. If you want to learn more about the ways you can take action, some of the resources on these slides are a really nice place to start. You can click those links on the slide deck as you go. In today's objectives, we're hoping to reflect on what it means to build a therapeutic alliance with someone who's affected by an eating disorder. We're hoping to explore different modalities and types of support for people affected by an eating disorder. And we're hoping to help you learn about relevant resources and referral pathways to best support your clients. Please know that you can ask questions throughout. We all have the chat window open, and both the chat and the Q&A are going to be monitored by the speakers who aren't speaking at that time. We also trust you to take care of yourself through this presentation. I think for those who have had difficult experiences with the conditions that we're talking about today, that sometimes hearing about these things in this context can be difficult. And I'm really glad that the CASW platform is there for you, that this can be accessed as an on-demand learning after, like Alexandra mentioned. If ever you're wondering about the sources that we're sharing, you'll see at the bottom right of most slides sources on where we pulled information from, and we have a full reference list included at the end. Please know that you are free to eat if you'd like or need to throughout the session today. Please take care of your needs as you're encountering this learning opportunity, especially with the ways in which COVID-19 has still continued to really impact our structures and our routines and our well-being. And please know that all of us are presenting from our personal and work contexts, and the more critical thinking, the better. We can just speak for ourselves, and we're not going to try to speak for more than just ourselves and the work that our organizations do and our experience in that. And we really trust and value all of your knowledge and experience that you can bring to this conversation too. So don't need to look at this content as like the way to do things, but as tools to potentially help you reflect on your practices and your processes and inform your critical thinking as you work to better support people affected by an eating disorder. I'll pause here before we get going. Anyone have any questions about that? Okay. Feel free if you're typing to pop that into the chat, but I really just wanted to make sure, as Alexandra's mentioned a couple times, that we've been really lucky and thankful to work with CASW on having this as a series, and this is part 3 of a series. For those of you who are like, oh no, I've missed part 1 and part 2, please know that that's accessible on the CASW On Demand platform, and these are the information that was covered in part 1 and part 2. An introduction to eating disorders really covered off basic information about the condition, including how to recognize it, the risk factors and commonly co-occurring mental health challenges, as well as exploring the ways in which eating disorders are interconnected with aspects of identity, including things like race and gender and sexual orientation, socioeconomic status, and body shape and size. And we ended that session with a practical piece on sharing strategies for assessment and providing support, especially from a motivational interviewing lens. In part 2, exploring diet culture and weight stigma, providing care for all, we explored topics around diet culture and weight stigma and health, really trying to use an anti-oppressive lens. We reflected together on the implications of weight stigma and the ways in which that can inform our language and our ways of being in practice. And we shared some tools and strategies for adopting eating disorder-informed approaches to care, especially from a weight-inclusive lens. So if you're looking for those things from this session, know that we might not be intentionally touching on them because we've covered them in the past, but some of what we talk about today will feature connections from those first 2 parts. That doesn't mean don't ask those questions. Just know that sometimes part of the answers that Caitlin, Aaron, and I might give you are to, we covered this in part 1 or part 2 if you want to go and give that a look. So feel free to do that. So as we get into today's content, I think someplace that is really important to start with as you're thinking about your role in supporting someone with eating disorders and in their recovery journey is to start by reflecting on the challenges and opportunities of your role. So on this slide, you see some challenges on the very left that Caitlin and Aaron and I have come up with, and some opportunities on the very right that we've come up with. We don't think necessarily that these capture every single challenge and opportunity, but we'd love for all of you to reflect on this list and to add things for us in the chat. What are some challenges that you have had to face in your role that you don't see on the left? Or what are some opportunities that you think you have in your role that you don't see on the right? Help us fill out this list, because I think all of us reflecting on our context is really important in determining our role and potentially the best way to support someone in our context for helping someone with an eating disorder. So take a moment and look at this and pop things into the chat. And we will also take compliments if you think our challenge and opportunity lists are good. Yeah, that's a really important challenge. Someone's bringing up lack of supervision. especially supervisors who potentially have eating disorder knowledge are able to provide consultation with a case that you've had. Someone else is bringing up lack of specialized resources, especially in rural and northern parts of the country. This person's from Manitoba. Not having a thorough understanding of eating disorders, disordered eating to recognizing in clients. So maybe that lack of training around that. Thanks. And we hope that part 1 at least helped a little bit with that. Stigma, yeah, potentially, and even like having a youth or really anyone potentially reach out and commit to ongoing support. That can be harder if you're in environments or in peer environments where you feel like that maybe is going to be welcomed or supported. This one's really important too, a refusal of services due to atypical presentations. You'll learn about this later on as we talk about the system, but there are many aspects of care in Canada where like we don't have provincially funded services for people with certain eating disorder diagnoses, like a really common eating disorder being binge eating disorder. There's not a lot, if any, of provincially funded care services for folks to access. So those things can be really hard and are really needed, especially given the prevalence of that condition. Someone's mentioning sometimes multidisciplinary teams can change the narrative for the good and the bad. Like if you're not sometimes having your critical thinking hats on, the team just becomes a group think about a client as opposed to different perspectives. Someone's mentioning eating disorders being put on the back burner and the focus put on other issues, especially by other professionals on their care team. That's important too. And I think there's lots of power dynamics that all of us might have to face as social workers in contexts where we're potentially working with folks who have who put more power in their degree credential, and like we feel like it's hard for us to maybe speak up and advocate on behalf of our clients. Understanding how to address eating disorders in clients with chronic mental health experiences, for sure. A lot of comorbid, co-occurring conditions, we have a lack of resources, a lack of training, and a lack of services being able to really treat the whole person. And I think you all run into that. Not having step up, step down treatment options, for sure. You'll get to hear about some of the things that Bodybird's doing in this area a bit later. Co-occurring things, people's personal biases and beliefs. We really tried to unpack that in part 2. Traditional and cultural practices such as fasting, so from a like spiritual or religious lens, can be really challenging to navigate when supporting someone who's potentially in a restrictive eating disorder, for sure. Media personalities and celebrities can be positive or negative in addressing these issues. Yeah, the influences that the client might have on them. I'm going to ask, I feel like you all have helped really expand that challenge box, and I'm wondering where you feel about that opportunities box on the very right. How do you feel about those opportunities there? Do you think that's too much? Do you think those are things you feel like you can commit to? What's on your mind as you look at that box of yellow? I hope that you notice too that there's nothing in that those bullet points that say you have to cure the eating disorder. That it's all on you, because it really can be difficult to do that. And I think you can be a positive part of someone's recovery journey, whatever that looks like for them. If you're a compassionate experience with someone in healthcare, you've helped open up some doors for them, you equip them with some resources. Some folks are adding, when people feel hopeless or stigmatized, we can normalize, validate, and give hope. We can almost kind of be someone's like positive cheerleader in a way, like a not only an accountability buddy, but also be able to kind of cheerlead someone on and provide that like cautious optimism about their journey. Someone's mentioning they can take this webinar information to colleagues and open discussion from a more knowledgeable place. That's a really wonderful opportunity. Being a positive role model, especially in regards to working with youth. Yeah, especially for many of you who are in community settings and not always in that like clinical individual office setting. Your own being as a human and the way in which you are mindful in the ways you're talking about eating and exercise and body image are all really important. Moving from crisis response to preventative programming and being able to advocate for that, which is a really important part of the profession, for sure. Being that like link to some of the social issues and the social dynamics that can be underlying someone's eating disorder. An opportunity to start a conversation, especially when like sometimes no one has ever asked about their eating before, and you even opening up space for them to do that can be really wonderful. Okay, thanks everyone. Feel free to continue to populate that, but I hope at least this has sort of been a grounding experience in knowing that I think it's important for us as we realistically think about our role in supporting someone's eating disorder recovery, that we start with a reflection of the challenges that we're facing so we can maybe acknowledge them and maybe plan around them and normalize some of the opportunities of the role, because I think sometimes, I know for me, I can feel like, oh my God, is there no one else in this person's life? Like, do I have to do X, Y, and Z? And I think that can be a not helpful place to be when you're trying to support someone. So let's move our conversation over for some strategies for cultivating a therapeutic alliance. I'm really open to all of your questions and thoughts and theories on your experiences that you'd like to share. But some ways that we can maybe build on some eating disorder pieces to some of these basic therapeutic alliance strategies are something that I'll cover now. So in terms of orienting, your clients might have expectations of therapy based on their previous experience or their experiences of their peers or what they see in the media. And I think we all can play a really powerful role in laying out the parameters of a therapeutic relationship from a place of care and safety and compassion. That can go to like logistics, like the place of meeting and the length and the frequency and the role, but also talking about things like confidentiality or being real with them on the role that you think you can play as you get to learn about their supports. Being transparent and honest can also help from an orienting perspective, and maybe even help you enter that relationship from a place of you and this client are going through a forest together and you're walking side by side. It's not really meant, in my opinion, for one person to be further ahead than the other or one person to be cutting someone off. I think you're going on that walk together. That ties into managing expectations, understanding what their expectations from this support is and understanding what your expectations are having coming into this support. This can include managing expectations about weight changes throughout eating disorder recovery. And it's really important to not really make specific promises about a client's weight. So you might have clients come in and say things like they don't want to gain weight or they don't want to have their body shape change as a result of treatment. And we might have a tendency to want to maybe promise or reassure, we won't make you gain weight above a certain number or whatever it might be. And I think those are things that are hard to do. Our bodies are really complicated, as you learned in part 1 and part 2. And so it's really mindful that we're trying to unpack where and which that expectation is coming from for the client, as opposed to, and checking our need to feel like we have to set that expectation. You can establish boundaries and expectations around your role. So I like to explicitly define my limits. So me I'm a registered psychotherapist qualifying here in Ontario. And so I'm not really qualified or feel knowledgeable in being able to provide the nutritional support, let's say, that someone with an eating disorder might need in their recovery. But I can maybe provide some support with respect to being an emotional space to process, being able to talk about psychological coping strategies or sensory, physiological supports. Like those are things that I feel comfortable doing. And you all being able to kind of name that with a client can sometimes be really helpful in establishing that alliance. In supporting autonomy, this one can be really tricky and I think is really important. Many who experience eating disorders may be experiencing a loss of autonomy or have experienced that in other, especially more like structured treatment settings, or maybe having lost a sense of independence in other facets of their life. The eating disorder itself can affect an individual's autonomy by challenging and changing life plans, by necessitating changes in relationships and disrupting someone's identity, and recognizing that this client has a need for autonomy and finding ways to support it in sessions to really make sure that they're the captain of their own ship can really help build trust in that relationship, and is something that's super important. And finally, identify confidentiality, especially when it might be helpful. Like, let's say, even if you're in private practice and you're working with someone and they might need some support nutritionally from a dietitian, let's say, when you're working as a part of a team, it's important that clients know if and how their information will be shared, and you have processes in which to say, that might be helpful for me and your dietitian to talk together about it. What can we share? What can't we share? And really getting to define that. Helping to make sure that your clients understand your contact with other team members, if any, and being able to talk about that transparently is something that can be important. A way that I like to talk about the Canadian healthcare system sometimes is it's not really a warm blanket. I think it's like a quilt. I think it's a patchwork of a lot of different kinds of supports, and a lot of systemic factors influence how many patches our quilt is even going to have. And sometimes we might feel like we have to work with our client to stitch together the quilt, as opposed to being able to give them a blanket. And maybe stitching together a quilt might be stitching together your support with a dietitian support, with a peer support, with a group-based support. And that's maybe the start of someone's quilt. Being able to kind of define that and get to talk about that actively is something that's important. And later on in this session, we'll talk about aspects of that quilt that we can share. Anyone have questions on this slide, or other strategies for cultivating a therapeutic alliance that you'd like to share from your experience before I move on? See a question, I'll come back to it. But one thing that I feel like is sometimes useful to think about, and this is borrowed from some folks working in emotion-focused family therapy, which we're starting to see a lot more of in Canada, especially as an approach to support people and families and carers who are all affected by an eating disorder. And the way to think about this is sometimes we, as therapists, as social workers, have these things come up, these emotional markers, which you can see as roots, and these behavioral manifestations, as you see as the leaves on this tree. So an example of how this might look like in practice is like, I might feel helpless and ashamed and scared because I don't have the training I need to help my client, and that might show up in a clinical experience as avoidance, as being like, let me refer you out. I don't know how I can help, so let's move it. Now, like, that might be important because it's important that our client get care from a competent provider. And I think what I really want all of you to do as you consider your role in supporting someone is being able to really unpack these emotional markers, these roots, and to make sure they're coming from a client-centered place too. I really love to believe that like there is no such thing as an unmotivated clinician. Like, I think I've simply been more motivated to avoid something worse from happening. And so that's why it's sometimes normal to respond in the way that we see in the leaves there, where we might be overly accommodating, or we might be criticizing, or might be rejecting. We're scared sometimes that those things are going to happen. And I think these are like traps that I think are really normal for us to run into. And it's really important for us to take a moment to reflect and unpack, where is this coming from? And is this potentially coming from a place that's client-centered, or is it coming from a place that's focused on me? And how do I manage the latter as I work towards supporting the former? A way that you all can do this, and I know this might look small on your screen, is the folks who came up with that analogy from the International Institute for Emotion-Focused Family Therapy put together this scale called the Clinician Trap Scale. And I found it potentially useful in you being able to reflect on it for your own experience, to note where you're going to run into traps. And because I really want to emphasize here that it's normal for you to do so, and it's okay if you do so. They're just potentially places that you might have to be aware of transference and countertransference in the clinical relationship, and where you might need to look for support for yourself from a supervisor, from a peer network, whatever it might be, as you run into these traps with clients. Because what isn't fair is if we're not aware of those traps and they're showing up in a clinical relationship and we're potentially rejecting a client or blaming a client or putting labels on a client, and we're undermining their care in different ways because of some of these traps that are there. So I hope that this can potentially be a self-reflection tool that you now have access to. You can click that link to get like a bigger copy and to read more about it. But feel free to reflect on that as something that might be important. And I think finally, before I pass it over to Caitlin, I want to reflect back on in part 1 where we talked about stages of change. As we think about someone's recovery journey of an eating disorder, it's really important to note that a stage of pre-contemplation where someone isn't seeing a problem with their current behavior can be really normal, given the societal messages that we see around diet culture that we unpacked a bit in part 2. That when we initially show up as we're like motivated to come play a role in a client's recovery because they're presenting to us and they're kind of unsure, or they don't really know if they want to tackle the eating disorder, or they don't really see a problem with X amount of behavior, whatever it might be, that this is a normal thing given the societal structures that we all live in. And that identifying that client is in pre-contemplation is important just for you to make sure that you're able to assess where they're at. And that these stages of change aren't really linear, that people don't always naturally move from pre-contemplation to contemplation to preparation to action, that people can bounce around among multiple of these things. And relapses, especially during a global pandemic, engaging in older patterns of behavior can be really normal in times of coping, and it doesn't invalidate where someone's at, even if they have been taking action. And so, again, a reminder from part 1 that sometimes it can feel like our clients and our work with them are spinning in circles over and over and over again. And I think one perspective shift that we can sometimes take for ourselves and with our clients is to really look at this from a side view, and like that bottom part of the image sees that it can be an upward spiral and progress is happening, and maybe the rotations are getting fewer and fewer or whatever it might be, because being able to be that grounded, cautious optimist with our client can be a really key part of our role. And so I'd love to turn it over now to Caitlin to talk about ways in which we can apply being trauma-informed can come into play when we're supporting someone with an eating disorder.
Thanks, Ari. I love that image of the spiral. I often will actually share that with folks in groups at Sheena's Place as a way of encouraging a reframe around some of the hopelessness or frustration that can happen with the recovery journey. So with that, I will shift us into a conversation about trauma-informed care for people with eating disorders. And so it's really important that we are working from a trauma-informed approach when supporting people with eating disorders and disordered eating, and when working with people without eating disorders and disordered eating. But especially in the context of eating disorders, available research does show us that there is a strong correlation between eating disorders and experiences of trauma. So people who've experienced trauma, especially interpersonal or sexual trauma, are more likely to develop eating disorders than those who have not experienced trauma. And this is especially the case for eating disorders with binging and purging symptoms like bulimia. On the other hand, people with eating disorders have a higher incidence of trauma than the general population, so this relationship does go in both directions. We know as well that 30% of people with eating disorders have experienced childhood sexual abuse, so this is quite a high number. Disordered eating can be a response to trauma itself, and it can also be a coping strategy or many coping strategies for managing other symptoms of trauma, including those listed on the slide. So things like anxiety and panic attacks, coping with depression or chronic pain, nightmares, flashbacks, hypervigilance, all of those things. So in the next slide here, I'm going to take us through some of the functions of eating disorder symptoms as trauma responses. And understanding symptoms with this in mind will be really helpful for supporting people with eating disorder symptoms. So if we think back to webinar 1, for those of you who are present, we talked about some of the perpetuating or maintenance factors for eating disorders. So what drives symptoms? What are the functions of symptoms? We know that symptoms are not simply a choice. People, don't flip through the catalog and decide that they're going to just have an eating disorder because it sounds nice, right? We know that there are so many reasons why symptoms are occurring for people. And many of these are things that are not evident or visible right off the bat. So there are a few examples here, and I'll go through some of them now. So for many people who experience physical or sexual trauma in particular, they may develop a sense of disconnection from the body or a desire to separate themselves from the body and the overwhelming emotions that they're experiencing. So this can, of course, impact self-concept, self-esteem, and body image, which can perpetuate eating disorder symptoms. We also know that body hatred, shame, and urges to self-harm due to self-critical views that develop after experiencing sexual trauma are quite common. And so in this way, it makes sense that, that symptoms can be related to that. Some survivors will also engage in disordered eating as a way to avoid traumatic memories and to cope with negative emotions. We know that, symptoms can be a powerful distraction from whatever else is going on in a person's life, something to focus on, something to control, perhaps. We know that restriction can impact cognitive functioning and memories, and this can actually help a person stay numb or dissociated. And similarly to substance use, studies show that binge eating and purging can reduce the hyperarousal or anxiety associated with trauma. Often folks will describe a physical release while binge eating or purging that allows numbing, avoidance, and forgetting of traumatic experiences. So in this way, eating disorder symptoms can be quite self-soothing. For folks who've experienced trauma, they may also feel threatened by uncertainty and not being in control because of whatever has happened to them. So controlling behaviors around food and exercise can serve as a logical way to cope with this feeling. One example of a way in which this can manifest, and this is especially for survivors of sexual trauma, is by using something like binge eating as a way to change the body or to gain weight, making the body, quote unquote, less attractive, of course, by diet culture standards, in hopes of avoiding sexual situations, contact, and intimacy that represent vulnerability to harm. So in this way, binge eating is often a protective response to sexual trauma. One example that we may have mentioned in part 1, Roxane Gay in her memoir Hunger provides a very powerful example of this. I will add a trigger warning there that she does go into quite a great amount of detail, but it is a really, really powerful and important read. So through these examples that I've just shared, we can start to understand that eating disorder thoughts and behaviors can be rooted in a desire to preserve and protect oneself. I personally really dislike the language of self-sabotage or self-destructive. I will never use that with clients and folks I work with, as it's evident that even, behaviors like self-harm and punishment are rooted in this desire to preserve and protect oneself. And so all of that to say, it's very common and normal for folks who've experienced trauma to have disordered eating, and understanding eating disorder symptoms in this way, as I said, is critical to providing care. So moving along to, I guess actually before we move on, I'll pause. Are there any questions at this point that anyone has? Any comments or questions in the chat? Feel free to share. And I'll do my best to address that. Otherwise, we can wait until the end. Okay, so I'll move on for now to talk a little bit about trauma-informed practices and how they relate specifically to supporting someone with an eating disorder or disordered eating symptoms. So a lot of these are probably very intuitive, and many, if not all of you, are already engaging in a lot of these things. But I think going through this serves as an important reminder that all of us can benefit from. So the first is remaining empathic and non-judgmental. This is probably the most obvious one. remembering to validate emotions. Clients with eating disorders often feel very isolated and alone. Many people have experienced a lot of invalidation or traumatic invalidation in their lives. And so validating emotions, being empathic and non-judgmental is key. It's common to get caught up in the details around the symptoms that clients are engaging in. But if we remember that all symptoms serve a purpose, many of those purposes connected to underlying emotions, really doing our best to explore and validate those emotions. In terms of being non-judgmental, remembering not to make assumptions about what a client is experiencing based on what you see or aspects of their identity. And we talked a lot about this in webinar 1. So again, I'd encourage everyone to check that out if they have not. Working with shame is also really important. Shame often shows up after experiencing trauma, and it can be very tied to disordered eating as a result of the stigma that exists around many of the symptoms. So if people feel shame as a result of experiencing trauma, and then they engage in eating disorder behaviors to cope, this can add layers and layers of shame to a person's experience. And so working through this, talking about shame, we often have, like Ari was mentioning, the tendency to avoid talking about certain things. And shame can be a big one because it's uncomfortable and shame doesn't want to be talked about. And so reinforcing that the eating disorder is not a choice, just like it's not someone's fault if they've experienced trauma, is really critical. Psychoeducation can be very helpful here as well, especially around the functions of symptoms like we've talked about, and about things like the restrict binge cycle that we covered in webinar 1. Learning this information can be really empowering, and it can really emphasize for people that it's not their fault, that what they're experiencing is not because they're bad or wrong or not doing what they should be doing. The psychoeducation can be really helpful in combating shame. And as I mentioned, framing behaviors as self-protective and not as self-sabotage or self-critical can be very effective in combating shame as well. Reflecting on beliefs and biases, we've talked about this a lot, especially in webinar 2, the fact that we're inundated with messages that thin bodies are healthy or more desirable or acceptable, and that fat or larger bodies are unhealthy or less worthy in whatever way. And so it's really important that we continue to work to unlearn this and to adopt weight-inclusive practices, as this is a really critical part of providing trauma-informed care. Acknowledging and validating our own feelings and engaging in self-care as well is a big part of self-reflection. So whether that's engaging in formal therapy or having access to informal supports, and reflecting on our own relationships with food and the body and how this might affect our interaction with clients. And knowing too that based on our own experiences, working with folks who've experienced trauma or eating disorders might not be something that you're ready to do right now or ever, and that's okay. So we will be providing more information at the end about resources for referral. Mindfulness around language too. We've also talked a little bit about this in webinar 2. But this includes observing how diet culture can sneak into our vocabulary. So using terms like overindulging or guilty pleasure, binging on Netflix, for example, all of these terms can unintentionally reinforce shame around certain behaviors. And it's really important, again, when working with trauma and eating disorders and shame, that we're mindful about how we speak with our clients and just in general. As well, avoiding comments on the physical appearance or food choices of our clients or even of ourselves in front of clients. Again, we talked a lot about this in our previous webinars. And lastly, remembering that recognizing or placing value on weight loss or gain can be especially triggering for survivors of trauma, as some survivors may actually associate a specific weight with their experience of abuse. So this adds a layer of complexity and adds yet another reason why we shouldn't be commenting on weight gain or loss of our clients. Next, with support, supporting with safety and boundary setting. Boundaries can help create safety and predictability, and many folks who've experienced trauma and many folks with eating disorders do not experience safety or predictability in many contexts in their lives. And so this is an area that social workers can be really supportive with. in articulating how client confidentiality and privacy will be respected. Ari also spoke to this a little bit. And providing clear information as to what clients can expect to occur while engaging in treatment, especially for folks who've never engaged in therapy or in that relationship before. That sense of predictability can really, really help create safety. Power imbalances can also be really common experiences of trauma. And so these can be counteracted by relationships in which survivors feel safe and equal and respected. So as a result of this, therapists or social workers should be aware of that power discrepancy in their relationships with clients and do whatever they can to minimize it. This can be, structured in different ways, making sure that clients have lots of option and choice, that clients have the right to reject or not answer certain questions or to choose what elements of a treatment or program they'd like to engage in. This can be really, really helpful in building empowerment and self-determination and agency, which ultimately can work against some of the negative impacts that trauma can have on a person. Lastly, on this note, coercive and punitive methods like using a reward or punishment system or any kind of invasiveness and lack of privacy, this can be very ineffective when working with any client, but especially clients who have experienced trauma, and it may actually be re-traumatizing for folks. Moving on to systemic trauma. This is very, very connected to the development of eating disorders, and we have spoken about this again in webinars 1 and 2. So systemic oppression like racism, transphobia, and fat phobia and the trauma caused by those systems of oppression can influence the development of eating disorders. People who experience the most impacts of diet culture are likely those whose bodies are marginalized in other ways. So through racism, ableism, transphobia, and more. So really being aware of one's social location, the connection between, what differences is this client experiencing in the world compared to yourself? Where can we bring that into the therapeutic context if that's what the client wants? And recognizing too that, these systemic forces, this may actually help externalize some of the eating disorder voice or symptoms, again, working to combat shame. Focusing on strengths and providing encouragement as well. This is something that, again, is very relevant to all forms of support, but really encouraging the client to see themselves as more than their eating disorder. So maybe that means spending time talking about other values or other things that are important to them, and emphasizing their strengths, which they inevitably have. And also being aware of how compliments can land with people, right? Some people are very resistant to hearing about their strengths. And so exploring that with a client may be of interest as well. One thing that's not on here is skill building. So really focusing on building other coping mechanisms or strategies. We know, as we've talked about so far, that eating disorder symptoms are survival mechanisms. And so as dangerous as they can be, they are still vital in the absence of other safer coping strategies. And so in order for a person to decrease the frequency or intensity of their symptoms or to relinquish them altogether, alternative coping strategies need to be identified and adopted. So I'll pause here and to ask everyone, is anyone already doing a lot of what I've just talked about? Or are there other trauma-informed practices that you are already using? We'd love to hear what folks are doing to work from a trauma-informed lens, either with folks who have eating disorders or with folks who don't. So I'll pause here for a moment. Give it a few more moments if there's anything anyone would like to add. What trauma-informed practices are you using? All right. If nothing's coming to mind right now, that's also completely okay. This is I think, an important reflection question to take with you out of today's presentation. I see a couple things coming in the chat. Yes, that is definitely, thank you, Lee, for raising that. It can certainly be a big challenge when supporting trans folks with eating disorders. Yeah, using non-judgmental approach, being empathic when asking. Yeah, so that's important when asking questions about, let's say, adherence to a meal plan, doing so in as neutral of a way as possible, right? It can be easy to ask leading questions like, oh, you completed your meal plan, right? But that implies judgment if they did not complete their meal plan. And so asking those questions non-judgmentally. So using language that reflects, that the person is not the problem. Maybe the context or the environment is the problem. Building goals that are realistic together. And we'll talk about building goals actually in just a moment. Yes, and thanks for that comment as well. I think, this content, while it is focused on eating disorders, it's very, very broad at the same time. Okay, so I'll move on for now. And if anyone else has any other thoughts or comments about trauma-informed practices, please share them in the chat. The last square that you'll see on the slide here is about harm reduction. And so that's what I'm going to spend the next few minutes talking about, in that harm reduction is a form of trauma-informed care. All right, so we often hear about harm reduction in the context of sexual practices and substance use, and harm reduction approaches have been successfully used to optimize the safety of people living with HIV and AIDS, and for people who engage in drug use and sex work. And we rarely hear about this term in the context of eating disorders or even other mental health challenges. But for people engaging in disordered eating behaviors, we can and should be applying harm reduction approaches to reducing the harm of symptoms. So symptoms like restriction, overexercising, binging, and purging. And so the three squares on the bottom here outline some of the core tenets of harm reduction. So harm reduction acknowledges that there are often safer ways to engage in certain behaviors, and we can non-judgmentally plan to limit the danger to a person's health and improve their quality of life. So we don't need to be taking an all or nothing approach, because often that actually doesn't work very well. Harm reduction also focuses on reducing the harmful effects of some behaviors, recognizing that abstaining from or eliminating those behaviors might not be a realistic or desirable goal, especially in the short term. So if we look at eating disorders specifically, we can't abstain from food and movement. These are things that are inherent and integral to living and surviving. And so while for some people, let's say working on, a challenge with substance use, maybe abstinence is the goal and that's what's going to work well for that person. But with eating, that's simply not really the case. I also realize I missed the box in the middle here. So essentially, harm reduction also accepts that behaviors, for better or worse, are a part of an individual's experience and occur for complex reasons that are not easy to fix. So a person exists in their environment, and we can't just look at a person and ask them to change or expect them to change their behavior without looking at what are all of the external factors and causes that might be contributing to behaviors that are causing harm. So moving on, some questions to consider with a client from a harm reduction approach. So it's important that a client is able to recognize for themselves, when to get help. So what are some warning signs that the client is beginning to struggle? Encouraging the client to think about specific thoughts, feelings, or behaviors that come up. Often there are signs or red flags that a person knows, like, oh, when I start to isolate myself, this is when things are going to escalate. Or when I start counting calories, or going to the gym more than once a day, that's when things are starting to get more dangerous for me. Coping skills, so supporting a client in thinking about what can they do by themselves to manage the concern, and what obstacles might show up when they try to use these coping skills, and planning ahead and problem solving around that. Working to set goals as well that reduce the harm of a specific behavior is really critical. And so on this slide, the underlined resource, Alternatives to Self-Harm, outlines some alternative strategies that a person can use as opposed to self-harm, and it uses different emotions to structure the recommendations. And while this is not specific to eating disorders, many, if not all of these alternative strategies can be applied as alternatives to symptoms as well as to self-harm. And we also know that sometimes eating disorder symptoms are a form of self-harm. Next, identifying social support. So who is in the client's web of support that they can rely on? If there are not specific friends or family members or healthcare providers, reaching out to helplines like NEDIC's helpline, like at the distress center in the region that you're in, if there is one, and thinking about supporting the client in identifying what to do at different levels of distress, right? So again, avoiding the all or nothing thinking. Like every time I'm in distress, this is what I'm going to do. That's probably not, the same thing's probably not going to work in every situation. And so maybe when the client is at an 8 out of 10 in distress, calling a distress center. And when they're at a 3 out of 10, calling a friend or family member. And really emphasizing for the client that they know themselves best. We can't, as social workers or therapists, create a plan for them. It really needs to be coming from within them. So next, I'll talk briefly about some of the targets that we can support clients in setting. And I won't be talking so much about specific symptoms. The article that is linked at the bottom here, it just says article about eating disorders and harm reduction. This article outlines a ton of different specific harm reduction strategies for specific eating disorder symptoms. So what are ways in which a person can minimize the harm associated with a symptom? Before getting into these goals, I'll give a couple examples of those. So one being with self-induced vomiting. This is a common purging method that people will use as a way to attempt to compensate for eating or for binge eating. And so there are a lot of things that a person can do to minimize the harm associated with self-induced vomiting before just stopping vomiting altogether. Because this, again, is a coping strategy that is serving a purpose. And if we ask or expect someone to just stop, this might actually backfire and make things worse. And so an example of one way that a person can reduce the harm associated with self-induced vomiting is by not brushing their teeth right after, as this can enhance or increase erosion of enamel. And so instead, rinsing the mouth with water. With restriction of food intake, taking multivitamins and eating safe foods, right? We'd rather a client eat foods that they deem safe than not eat food at all. So this is a really good example of a harm reduction type of goal. Now, when we're setting specific goals with people, there are a few things to keep in mind, which I'll go over before passing it over to Erin to finish our presentation today. So the first thing that we want to support clients in doing is to set concrete and specific goals. So for the purpose of this slide and the next slide, the example of running is used. So maybe a person is engaging in over-exercise, specifically through running. They're running a lot to the point that it's causing harm physically, emotionally, mentally, socially, all of that. So creating a goal that is concrete and specific, we know this through SMART goal setting. For folks who are familiar with that acronym, that is going to be more effective than setting a vague goal. So the example here, changing running frequency from daily to 4 times a week, as opposed to the goal being, I'm just going to change my running pattern. It's also important that goals are doable and realistic and not too big or too difficult. So again, we want to avoid all or nothing thinking or an abstinence mindset here. If the goal is, I'm going to stop running altogether, that might actually backfire in that if the person is unable to meet this goal because it's so big or difficult, this could increase feelings of shame, self-criticism, and hopelessness. And so setting a doable or realistic goal, the example here, only running after a meal, this ultimately is a better idea according to harm reduction. As well, setting goals that can be quickly and easily monitored, as opposed to goals that are ambiguous or lacking guidelines. So this means that the person will be tuning into their thoughts and emotions as they engage in behavior, which can, of course, be beneficial in many ways. But if a person is unable to track how the goal or progress towards that goal is going or how it's making them feel, then it's really difficult to move forward or to step back and assess how things are going. Next, it's important that goals are prioritized so that the immediate target focuses on minimizing risk from the behavior, and then the long-term goal focuses on improving comfort. So again, with running, the immediate target could be making sure that a person is only running after they have an adequate nourishment in order to allow them to do so, right? If someone goes for a run and they haven't eaten anything that day, there are a lot of bad things that could happen. And so that initial goal being the immediate risk, and then future goals being around, okay, what kind of movement can this person do that is comfortable and enjoyable, as opposed to starting with a goal like that. And then lastly, setting goals with support or a plan. So making sure if we ask someone to just start working on a goal, even if it's one that they've identified, but there's no support in place to help them achieve that goal, again, we might be setting them up for disappointment or failure. And so if a person has supports like, I'm going to work towards my goal and then I'm going to call this friend, or I'm going to attend this support group. Or if I have the urge to go for a run, what am I going to do instead? And so supporting people with problem solving and working on alternative coping strategies. So that's where I'll end the harm reduction section for today. There's a lot more we could talk about. And again, I'll refer you to the article at the bottom. This is something that's being more and more talked about in the eating disorders field. It's something that, like I said, is not commonly addressed in this context, but it's really important that folks are taking this approach or considering it when supporting people with eating disorders. So the last thing I'll show you before passing it over to Erin is this web of support. I apologize if it's small on your screen, but you should be able to see it larger when you download it. Essentially, just reminding everyone that having a web of support is important. It's impossible or very difficult for a person to recover from an eating disorder on their own or with only like one type of support. And everyone's web of support is going to look different since everyone has different needs. But there are some examples here of different categories of support that folks might find helpful. And at the end of today, we will again be providing you with more examples about each of these different types of support. And with that, I will pass it over to Erin.
Awesome. Thanks so much, Caitlin. We are now going to spend some time kind of just going through different types of support. And so we've touched on a lot of these kind of different things throughout the conversation, and some of you have mentioned them in the chat or in the Q&A. And so we're going to spend a little bit of time just kind of diving into them. Obviously, we could do entire courses on these types of support, and people have, and we have those resources available in the slides if you want to really dig into any of these or learn more about them. But we just want to provide a bit of a quick overview. For people with eating disorders, the idea of recovery can be really overwhelming or downright terrifying. So it isn't easy to reach out for help and much less to really begin the work to work towards recovery in a meaningful way. So finding the best and most appropriate treatment option for each individual takes time. You might need to try a few different approaches, or they might need to try a few different things. So we're going to explore a few of the most common therapies and program types for people who are experiencing eating disorders. So there's psychoeducation, which Caitlin talked a bit about, which can be really empowering and help to reduce shame, kind of those skill building and understanding what's happening in their experience. Support groups and peer support can help in reducing isolation, enhancing connection. Eating disorders can be kind of conceptualized as relational challenges, and there's some great peer support resources that Ari, I think, put in the chat. Maybe it was the Q&A. But Sheena's Place does some great stuff around peer support, as well as Eating Disorders Nova Scotia does some great work around that as well. Nutrition counseling can be really helpful to have clients understand nutrition in meaningful ways, and so it's important in those pieces. It's really, really important if we are having those conversations with people struggling with eating disorders, that the dietitian or nutritionist that they're working with is eating disorder or health at every size informed to ensure that they're not doing more harm than good. And that experience isn't detrimental to their recovery. And then there's medical supports as well. So the physical consequences of an eating disorder, dehydration, osteopenia, that kind of stuff. People may need support in that ways, and medication to treat concurrent conditions as well, such as anxiety, depression, or ADHD. And then, of course, there's psychotherapy, which we are going to kind of dig into a little bit more over the next couple of slides. So family-based treatment, FBT, is a treatment option for children and adolescents with an eating disorder. It is primarily specifically designed for people who live at home with their family. That's kind of an important caveat within the experience of FBT, is it's the family unit kind of working towards recovery, and so living at home is an important part of that. So it's normally for children or adolescents. And currently it is the leading treatment for adolescents struggling with eating disorders. An important caveat to that, which was brought up in the Q&A, FBT uses the parent-child bond as a foundation for treatment, so it may not be for every family. Research has shown that it is highly effective and maybe faster than other treatments, but as was mentioned in the Q&A, FBT is often seen as the best practice, but if the family dynamic is abusive or toxic, FBT is not likely going to be a treatment approach that has positive or recovery-focused outcomes. So really important that at the very least there's kind of that foundation of a child-parent bond that is based in respect. That's kind of the very, very base of that. If that is not there, or if it is not a healthy, or conducive to a therapeutic kind of alliance between parent and child for that family, then FBT is most likely not going to be an appropriate option. So for lots of families, it is a great option, a great approach, but for others, it should not be kind of the only consideration. So FBT focuses on expanding treatment outside of the clinical setting and bringing it into the home and kind of the everyday life of the client. So families as a unit are provided with skills, resources, and have an active role in the client's treatment. So there's 3 phases that they kind of go through as the person recovers. So phase 1 is full parental control. So the parent is really kind of in control of the kind of refeeding process, meals, that kind of stuff, especially for people who have struggled with restrictive eating disorders for a while. They don't have hunger cues, or they, going to the fridge and making a meal is not an automatic response for them. And so having someone who, has those hunger cues and can be saying, this is when we are going to eat, and that kind of stuff is really, really important. Phase 2 is kind of that gradual return of control to the individual who is struggling. So kind of slowly the person gets their autonomy back and kind of helps with some of those eating processes as well. And then phase 3 is kind of establishing that healthy independence. So the person kind of takes that control back and is in their own space doing those things. So again, not fit for every single person, but a good resource for some. And there is a link there to a training that is specific to FBT. It's specifically for anorexia nervosa, which is what FBT is primarily used for, but can be a good resource for anyone kind of just interested in learning a bit more about FBT more generally. Okay, fantastic. Cognitive behavior therapy is the leading evidence-based treatment for eating disorders beyond FBT, and for eating disorders more generally beyond just restrictive or anorexia nervosa. So CBT is a psychotherapeutic approach that involves kind of a variety of techniques. Most of you are probably fairly familiar with CBT, so I don't want to bore you with my understanding of CBT, but it is often the first line of treatment for adults with bulimia nervosa and binge eating disorder. It's not normally recommended for people who are severely malnourished due to kind of a lack of cognitive processing abilities. And so they don't necessarily have the full ability to engage in that therapy adequately. But maybe later on, when that kind of refeeding has begun and they're back to cognitive processing in the way that they would like to be, it's a good option. So in 2008, an updated manual for enhanced cognitive behavioral therapy, or CBT-E, as we see there, was released, and it was designed to treat all eating disorders. So it was kind of comprised of two formats. A focused treatment, which is similar to the original, and then a broad treatment with extra kind of modules on mood intolerance, perfectionism, low self-esteem, and interpersonal difficulties that contribute to the maintenance of eating disorders. So some examples of processes within CBT, or what that might look like for individuals with eating disorders. Kind of the cognitive challenging of dietary rules. So identifying what rules someone has about eating or their body, or the maintenance of their body, and then challenging them behaviorally. So kind of going against what that rule is. A development of continuum thinking to replace all or nothing. So rather than black and white, really kind of creating that gray and exercising the muscles of creating that space. And the use of behavioral experiments, even. So, for example, if a client believes that eating something will cause them to gain X amount of weight, they would be encouraged to eat that thing and then kind of experiment to see if it does cause them to gain that weight, which it most likely will not. And so those kinds of things are a big part of CBT, and there is a training there as well if you want to learn a little bit more about those specifics. DBT, or dialectical behavior therapy. It is kind of an offshoot of CBT, and so it helps to connect cognitive and behavioral therapies as a way of helping someone learn and adapt healthier methods of coping with painful emotions, and kind of through acceptance and change. So it's based on the model that assumes that mental health problems are largely caused by an inability to handle our emotions properly. And so if that's something that a client is struggling with, is kind of those big emotions or the emotional capacity, DBT could be an option for them. So it works to address kind of under control, which is what we might call binging or purging, through kind of the four main skills, which are distress tolerance, emotional regulation, and interpersonal effectiveness skills, and mindfulness. For this to be a part of their treatment, regular eating does have to be a part of the client's life. So again, similar to CBT, if someone does not kind of have the cognitive capacity to be taking part in this type of therapy, it might not be the best approach at this time. So DBT in its traditional form can be really effective in treating binge eating disorder and purging through emotional regulation, distress tolerance, and mindfulness. And then RO-DBT, which is radically open dialectical behavior therapy, is a newer form of DBT that addresses over control, whereas traditional DBT addresses that under control. So it's DBT helps supporting individuals increasing flexibility and reducing rigidity and perfectionism. So traits that are more traditionally associated with restrictive eating disorders, like anorexia, as well as people who might be on the autism spectrum or struggling with autism spectrum disorder. So of those four main skills, some examples of what that might look like for someone who is struggling with an eating disorder. Under mindfulness, the mindfulness skill, you might practice mindful eating. So the practice encouraged that during meal times, someone is eating mindfully, rather than maybe experiencing that loss of control that they might feel when they are binge eating. They are encouraged to focus on the food and what does it feel like and taste like and smell like and those kinds of pieces, is really bringing that mindfulness into it. Distress tolerance involves learning to tolerate negative emotions or crisis situations without responding in the ways that might be a coping technique for them, such as binging or purging. And so really building an awareness of emotions and then slowly building those skills to respond to those emotions in different ways. And Dr. Nita Federici has a great DBT specifically for eating disorders training that is linked there. Acceptance and commitment therapy is another one. It has its roots in CBT, and it's considered to be like a third generation of the behavioral therapies that are designed to help clients to commit behavioral change and manage their emotions. So it's based on therapies that focus on behavioral change, such as CBT and DBT. So ACT challenges clients to choose different behaviors despite distressing emotions that might be present. So it's an effective treatment for eating disorders because it encourages more flexible and inclusive sense of self that is anchored in kind of the direction of one's values. So it's really, really focused on what is someone's values and how can we live in accordance to those values in our actions or in what we are doing. So clients can reflect on their values, ways of accepting they may not like their body right now, and how can they move towards their values even if they're not liking their body right now? What would that look like, or what would that involve in terms of their behavior for them to live in accordance to those values that they've spent the time to identify? And then they practice acceptance while still addressing the very real cultural challenges around body acceptance, and not negating those in any way, but then kind of work towards still living in accordance with their values, even though they're all are kind of all of these other aspects, and how can we cope and live a life that we feel more aligns with our values versus societal values. And so there are kind of a couple different aspects of ACT that are really, really powerful. One is cognitive diffusion, which centers on an individual's ability to have an experience without their thoughts or feelings dominating the event. So someone living with an eating disorder is being urged by a family member to seek professional help. And rather than maybe shame or anxiety or anger kind of rising up and completely dominating that experience, perhaps they can still feel that shame. They might still recognize that shame. But cognitive diffusion would be to acknowledge that emotion and the concerns and then kind of move forward. And so recognizing that emotions are a part of life and they are there, but they don't necessarily have to be at the steering wheel. They can be passengers to that experience rather than the driving force. The next one really quickly that we'll cover is motivational interviewing. We covered this a lot more in depth in our first session that you can have access to the recording of. It's a form of talk therapy and kind of a guiding style of communication that encourages clients to take control and focuses on the need for change. So very much connected to those stages of change that Ari talked about earlier. So it's the process of recovering from an eating disorder, and it's not easy kind of going through those stages of change. And motivational interviewing is just kind of meant to help kind of move around that wheel and up that spiral. And so there's lots of great examples that we put into that first training that you are welcome to go through and look at. But it's really listening to the client, observing that client, and looking at where they are in terms of their ambivalence or willingness to change, and then how can we kind of help support them wherever they are. And the eating disorder toolkit for primary care providers in BC has a great document on that there as well. Excellent. And there are, of course, a lot of additional therapeutic modalities that are really, really important that we are not going to touch on in depth, but really important for us to mention. So these are options that maybe haven't necessarily seen funding for, or have been able to have them necessarily be the go-to evidence-based, but have been around for a really long time and can be really, really powerful parts of someone's healing. So land-based healing, education, or treatment are vital when it comes to culturally safe models of care for Indigenous peoples who are struggling with mental health issues more generally and eating disorders. And so these are practices that should not be undertaken by non-Indigenous people, but all practitioners, I think it is helpful to have an understanding of and appreciation for these treatment approaches to help support clients who may benefit from them or participating in them. So it's important that we think about culturally safe models of care and what will most benefit our client and their needs. Expressive therapies such as art, dance, or even yoga are designed to promote physical and emotional healing. So these forms of therapies are not necessarily concerned with the specific therapeutic outcomes, but more concerned with the process, and most often giving the client the opportunity to really connect with their bodies in a very kind of physical, specific way. So music therapy can work in a lot of ways. Music being played during meals to help reduce stress. Lyrics and songs might help in terms of getting people to talk about things that they might not be willing to or able to specify in their own experience. Dance therapy tries to show how actions are connected to your feelings, and helps people to kind of really make that connection between mind and body. And then art therapy, using drawing or paintings or any kind of visual arts or dramatic arts, improv, those kinds of things, give people a way to express and explore their feelings in different ways, and kind of also help facilitate that mind and body connection. Guided self-help is another option that we might talk a little bit about. So with eating disorders or mental health in general, a lot of recovery occurs outside of the clinical setting. And so this can be a useful tool to help patients gain control over their lives, do some of that processing themselves, and they can explore different tools like self-help books or other informational resources. So there's lots of treatment options. Treatment for eating disorders is not a one-size-fits-all approach. It can take a lot of trial and error, but that's just a few of the resources that are available and some extra resources for you to look at there. And I'll hand it back over to Ari for the next couple of slides.
Yeah, appreciate everyone taking a moment to take in all that information. These next two slides look overwhelming, but I hope that as we go through them, the pathways will become clear, and I hope that at the end, when we offer you a resource to help you navigate that yourself, we're able to do that together. So the key word over these next two slides is common pathways, as in they're the ones that our services at NEDIC through our toll-free helpline or our chat service encounter most frequently as we help people navigate the system of care for eating disorders. And we start often on a medical pathway with primary care providers, and that might be someone's GP or family doctor, or that might be someone's pediatrician, or that might be a walk-in clinic. I think it's really important to note that many people across the country don't have access to a regular family doctor or a primary care provider, and I really want everyone to know that it doesn't matter if someone's following you. It doesn't matter if you don't have a regular provider, if all you're looking for is a referral to a hospital-based program, in that a walk-in clinic can also provide that referral. So you can see that arrow there between primary care provider and specialized hospital programs, because you do need a referral from a doctor to get access to any of our provincially funded care programs across the country. And that might refer to inpatient care, to day treatment care, or to outpatient care. What's really important to note is that patients don't often get a say on the type of program that they fit in once you're assessed by a hospital. The system is very chronically underfunded and under-resourced, and so the assessment is almost purely based on the assessments of needs by that intake worker and by that hospital to be able to see what program might be most available for that client, and based on the severity of their needs too. So it's really important, if we're talking to a patient, to a client, about expectations around hospital-based care, that we are setting those expectations appropriately, that we might not get to choose if it's inpatient or day treatment or outpatient. And I think we are very much in a period of flux and change as a system at the moment, given the way in which COVID-19 has impacted common ways that many of these programs operated. And as everyone figures out what the word hybrid means, we're all going to have to encounter that too. But this is currently the way that this is set up. The last point that I really want to draw your attention to on this slide is that bottom left corner where it says emergency department. It's really important to note that the ER does not let people bypass wait lists for hospital-based programs in most cases, which is why there's no arrow connecting the emergency department to the hospital-based programs. Often where that's helpful is if if a client maybe needs medical stabilization, or there's risk involved, or there's cases of a medical emergency. And for many people with restrictive eating disorders, that might include things like feeling faint or feeling heart palpitations or chest pain. Those might be signs that bodies and organs are starting to feel the effects of an eating disorder or co-occurring conditions. So that's something that's really important to note. I'll move on to the next slide, which covers common mental health pathways to receiving treatment and support. And so there's two main clusters here that I'm going to draw your attention to. The public services cluster in the top left, and right underneath it, that private services cluster. And let's start with private because I think it's a simpler one to explain. Private services are fee-for-service services. They may be covered by private health insurance, and self-referral is often accepted, except for some residential programs. So often many of us are providing individual or group therapy in a private way on an ongoing basis, and often with folks who are specialized with treating eating disorders is helpful. And there are also some residential programs in Canada, but there are very few, I think, when you compare us to our neighbors in the South. And so I very frequently will have clients ask us on the helpline, like, where are the residential programs in Canada? Because folks have been Googling and reading experiences of people who have received support in the US, where residential is really common. And unfortunately in Canada, I feel like it isn't as common nearly to the same amount. Where residential can be really helpful is that interprofessional care delivered in a home-like environment, especially for folks who are at the point of medical stability, but are really wanting to experience some of that psychological change that's there. And in Canada, there are some programs that are private and some programs that are public, which is why there's both of those arrows connecting to residential programs. If we move to public services, by this definition, it's free or covered by provincial or territorial health insurance. And some of the ones that I'm really going to focus on are community-based programs, because you have examples of them presenting here with me today. Some of us provide individual or group therapy that's often a bit more time limited. It might not be specific to eating disorders, and there's often a wait list, but that can be an option in some communities. There are many providers who are able to provide support and skill building groups. So these are structured or open groups focused on providing a space for collective healing and or building adaptive skills. Some of these may have a wait list and some of these don't. And then there are many wonderful peer support programs. Erin gave a shout out to Eating Disorders Nova Scotia. There's also Looking Glass, British Columbia. There are some folks who are providing that kind of support across the country, whether that's online, whether that's in person, whether that's group, or whether that's individual mentorship. There's a real variety of chat versus video versus meetings that can happen through peer support. And we're really starting to see advances in this area, thanks to the hard work of community-based organizations. What's really important to note is that navigating the system can be really complicated for many people. And so as we work our way to talking about the work of our organizations and where we fit in as we wrap up our webinar, I want everyone to know that NEDIC exists for this reason. We have a national toll-free English-speaking telephone helpline and an online web chat service that supports people across the country. We have thousands of contacts every year, and 65% of them or so are people who are personally affected who are reaching out for support, but a good 1/3 of them are friends, our carers, our professionals trying to look to navigate that same complex system that I've gone through in 2 slides with you, and trying to get support for their loved one. So please know that you can reach out. It's anonymous, it's confidential, and you don't need to refer, you don't need a diagnosis or anything like that to access. And we have a searchable online directory of 700 plus treatment and support providers across the country that cover off that private services, that cover off our provincially funded services, that cover off our community support groups, where you can learn about resources to best equip your client, resources that are health at every size informed, follow a non-dieting philosophy, often practicing from a weight-inclusive manner, and have identified training in eating disorders. And that's why we have that publicly available for people. So please do use us if you feel like you need help navigating that pathway. But I hope that us going through that a little bit with you here was helpful. And I'm gonna turn it over to Kate.
Hi, everyone. So just quickly about Sheena's Place. We are a community mental health charity
in Toronto, and we support people with lived experience of eating disorders and also caregivers and loved ones. We exclusively provide group-based support, so no individual therapy or treatment. All of our groups are free of charge and no diagnosis or referral is required. The only eligibility criteria that we have are that folks have to be at least 17 years old and residing in Ontario. So unfortunately, that only applies to the one province. But for those who are in Ontario, we are currently offering about 30 weekly groups online. This includes the general drop-in support groups you see listed on the slide, but links are included here for the full program calendar, as well as for info sessions to learn more. These are open to your clients and also yourselves, anyone who wants to attend. And registration for our winter season will start this coming Monday at 10 a.m. And in addition to our groups, we also provide outreach and education opportunities like this one, as well as trainings for smaller teams of healthcare providers or people in supportive roles. So please reach out if that's something you're interested in as well. And I'll pass it to Erin.
Thanks, Caitlin. Body Brave is a community organization, a charitable nonprofit that we are based in Ontario, and we very much work from a stepped care approach. We do not go all the way to the top of stepped care with inpatient hospital-based treatment, but we kind of cover a few of these different steps. So people kind of enter at the beginning, the entry step, which is self-guided support, psychoeducational workshops. We have these weekly sessions called recovery sessions that are people with lived experience kind of sharing their story on a topic or those kinds of different pieces. Last week it was coping with bad body image days. Then we have a self-guided support program. So people walk through kind of those self-guided pieces through one of our apps called Care Team. Not one of our apps, we only have one app. But it's called Care Team. And so you are connected with kind of the Body Brave community in that space, but are kind of going through a self-guided process with a few additional supports. And so that is open to anyone 17 plus across Canada can be accessing that support. And you can find information for signing up to that on our website. There's no need for a referral or a diagnosis, so people can sign up themselves, and we have lots of people who do, or people can encourage their clients or others to sign up. A step up, we have group treatment. So we have drop-in groups as well as 10-week closed groups on a variety of different topics. So we have Living Body Brave for people living in larger bodies, typically struggling with binge eating disorder. We have On the Journey, which is more about maintaining recovery and staying in those spaces and those kinds of things. And so people can enter those spaces as well. And a step up from that, if clients need it, is one-on-one specific treatment. That's kind of on a limited as-needed basis. So we provide medical assessments, psychotherapy, and then 10-week guided self-help specifically with a healthcare provider. And then we also, kind of on that base level there, have education and prevention as well, specifically for professionals. So we have an entire course for social workers and psychotherapists, a course for dietitians, and a course for physicians and primary care providers that are asynchronous, so they can be done on your own time. They're all virtual and just kind of go into depth about some of the things that we've talked about today. And so that is Body Brave. That is the work that we do, and how your clients or individuals who are struggling with eating disorders can get involved. The next few slides are just resources for your use. So please download these slides and you will have access to all of these things forever. So eating disorder treatment, we go into treatment programs, hospital-based programs, as well as general support, virtual support, nationally and internationally, all of those pieces. And then we have resource recommendations, so general information, trainings, all of those kinds of things as well that are there for you and you can go through and access. I don't know that we have time for questions. Is there anything in the Q&A that anyone else would like to... Oh, Alex is here. She can take over.
Hi. I know we are a little bit over time. I'm actually going to bring everyone online if everyone's okay with that, Ari and Caitlin as well. So we are kind of close to the end of the time, and I do see that our wonderful presenters did answer people's questions in the Q&A already. But for folks who do have to hop off, feel free to hop off if you do want to log back on for this little Q&A piece that we're going to do here for a couple minutes. You can come back on when this is a recorded version or whatnot. For those of you folks who can stay on for a couple minutes, we're just going to do a few questions, but what phenomenal content. So I don't want to wrap it up just yet. One of the questions in the chat was interesting, and I do see that Ari did respond, but potentially wanted to and Aaron responded, but potentially wanted to discuss it out loud. What about not discussing the harmful effects of having excessive weight? What if the client asks about this? I think that's an important question.
Yeah, thanks for bringing it up. I'll read out. I realized that the answer was private, and so I think it's a great question that other folks might have been thinking about. One strategy that I know I like to try with clients is get to unpack how they define health and help them see their health beyond just weight as a focus of support. As we talked about in part 2 of this session specifically, weight is a determinant of health, but in many cases, people's focus on it overvalues how much weight actually determines when we're talking about health more broadly. And so we will obviously have clients ask us about these things. And I think I like to, from a non-blame perspective, come from a place of let's unpack the reasons why you're asking about it and where you've heard these things, who's influenced your relationship with your weight, and fundamentally try to get to where are your goals on as a human in general, and where do you want to be, and how do we make that conversation broader beyond weight. And I don't know, Aaron and Caitlin, if you two want to add on to that.
Yeah, I added on really briefly just to what you said in the Q&A there, Ari, but yeah, just moving beyond whatever that kind of specific excessive weight might be, and looking at what is underlying that. So if it is fear of excessive weight or those kinds of things, is it really just a desire for a more positive body image, and really, making the connection that body image is not related to your body, but it is related to your mind. And so it is a change of the mind that has to happen in that space, and making sure that that's kind of what you're addressing. Is what they're actually trying to get at if you're talking about excessive weight. And yeah, maybe that means having them define recovery or define health in those different ways, just like Ari said. Yeah, that's all that I would add.
Wonderful. Okay, one of the other questions here, which you did also respond to, but I will say out loud because some other folks might have the same question. Can you say a little bit more about the social location and prevalence? Working with youth, it doesn't seem like the systemic impact is clear. Rather, the social construct of the adolescent environment. I'm interested in hearing more about your thoughts on this. Thanks. Yeah, this is an interesting worded question. Are you guys good to take it on, or do you want me to try and tease out a bit of it?
Yeah, I think I can try. I appreciate the question asker helping us deconstruct it a little bit. It sounds like the thing to talk about is how do we bring up that intersection of the larger system as well as the individual's direct social system that's being in there. And I think when we're bringing up unpacking that as a recommendation when we're talking about trauma-informed approaches, I think it's opening up space within our environment with a person to name those things. I believe that we have a lot of power as humans who are trying to help in acknowledging things as potentially being part of their experience. And when we name them, we give them validation. And if we give them validation, we potentially open up conversations where the client then gets to lead a conversation on how their relationship with their parents, or how their relationship with their food insecurity, or how their relationship with their race, or whatever it might be, come into and inform their experience with an eating disorder. To me, at least in my way of working, your experience with an eating disorder, it just happens to be the way that stress has decided to manifest at that time. It manifests in the relationship that causes disruption around eating or eating related stuff. And so to me, it can be workplace dynamics, it can be peer group dynamics, it can be stuff on social media, whatever it might be. But if we name that that can be a reality for someone, and we like give that to a client to see if they're willing to go there, then I think we take their lead on whether they're willing to go there or not. But I think it's on us to name it, so that way clients don't have to feel like they have to sit in that messiness, in that like very tangled ball of yarn by themselves. I think we can help them pull out strings to the extent that they want to actually take the string and start pulling. Is my approach.
Yeah, I think in social work, we use the term social location a lot to try and identify the systems around us and how we fit in within our social context in the systems around us. I do see one of the pieces saying that, are there any specific areas of prevalence that we should be considerate of according to research? I'm not sure what areas of prevalence you're referring to.
Yeah, I can touch on this, I think, briefly. If you mean areas of prevalence as in like certain communities or certain identities of experiences that seem to be more at risk for an eating disorder, the two that I think all three of us, like Caitlin, myself, and Aaron, all generally highlight are folks belonging to 2S LGBTQ communities often are at higher risk of experiencing eating disorder, disordered eating stuff. Some statistics show like even 5 times higher than their cisgender heterosexual peers. And so if you have a queer client or a trans client or someone navigating their gender in different ways, like opening up and then making sure we're asking questions around their eating or their body image or their movement and their relationships with that, I think becomes extra important because they're likely having to navigate something around that. The second kind of experience is like a class-based poverty intersection with food insecurity. I think that is also one where we're seeing more and more research come out on how both dietary restraint and potential binge eating sometimes come up as responses to food insecurity that can often have like a lot of complex emotions with someone around like the guilt or the shame that someone now might feel if they are trying to save food for family or potentially now overeating an aspect of their food and feeling out of control while doing so when they felt like they should have been able to conserve that. All of that can happen because of the ways in which food insecurities like really put our own relationship with our body cues out of whack. And so I think from a social location perspective, those two communities are the ones that come up for me, Aaron, and Caitlin. But feel free to jump in, you two, if you have anything else.
I'll just point to what I commented in the chat, which is that we do provide more information about prevalence and different communities who are affected and what some of those intersections look like in the first webinar. So you can check that out if you have not already.
Yes. Okay. Well, in closing, we actually don't have any more Q&A messages. I think we got through a lot of them during the presentation. It is so wonderful to be joined by such great presenters. So just a huge thank you to all three organizations for the time, effort, energy spent. There's a lot that goes on behind the scenes before we come live for you today. So just a huge shout out to our wonderful presenters for all the work that they've done on not just one, not just two, but 3 parts of this series for social workers. Please feel free to utilize those recordings. You just register normally. It should bring you right into the system, or use your registration confirmation emails you get to access any of these recordings. We will be sending out a final, now available on demand for all 3 parts email. So you can watch out for that, or send it to your peers, to your colleagues, to your bosses, to fellow students. If you're a student joining us today, this is a very, very, very important field of social work that we should be spending time learning more about. Your certificate of attendance will be emailed to you about an hour after the presentation concludes. So watch your email for that, or feel free to log back onto the platform and download it here directly. As always, we love to hear your comments and your feedback in the survey that'll pop up on the screen after this presentation has concluded. Since this is the end of our 3-part series, please do fill out that survey and let us know how you processed this whole series and what you thought about it, so that we can build and grow over at CISW. I'll give my final words to our wonderful presenters. I'm sad this is the last of our 3-part series, but excited for the future that we have to collaborate and partner in the coming months, years. But any final thoughts before we wrap up today?
I don't think so. Just thank you so much to everyone for joining and engaging in these conversations. We are so thankful for all of your work as participants throughout these 3 sessions, and thank you so much to CASW and Alex and everyone for having us. It's been so fun.
Wonderful. With that, we will end it. Thank you all. We'll see you at the next time.